because in numbers, we will defeat ALS.
We are so excited to actually introduce Dr. Appel, who has actually joined us today. And I'm going to introduce our teammate, Lisa Deegan, first, who is going to actually welcome all of you and introduce Dr. Appel. And also we have Zoe, whom you met, Zoology, and James, who are our student ambassadors, who will be actually moderating the questions in the chat. So if you have any questions as we are going through, please feel free to ask any questions on the chat, and we're gonna try to get to all of them. If not, we'll get back to you afterwards. And also wanna let you know that all of this is gonna be recorded, Dr. Appel's conversation. So it will be available on YouTube. So what we would ask you to do is go to YouTube with Everything ALS channel and subscribe. So once you subscribe, when a new video comes out, you get notification immediately. So make sure you subscribe to Everything ALS channel on YouTube. And with that, I will invite Lisa Deegan to actually address all of you.
Hello, everyone, and welcome. I see lots of new faces, and I see a lot of familiar faces. So thanks, everyone, for joining. I am Lisa Deegan, as Anu said, and I'd like to start off with sharing with you guys how fortunate I feel to be a part of Everything ALS, because I lost my younger brother, John, to this disease in 2018. So since our launch in April 2020, we have over 1,700 subscribers to our website, which is, it's been growing so fast, and over 15,000 views on our YouTube channel. So everyone on our team has actually been affected by ALS. So everything that we do and execute on is something that all of us wish that we had during our journey with our loved ones. So it's exciting to be a part of a platform that's actually bridging the gap and bringing down silos for all who are in this fight for finding good care and a cure for ALS. So this is a place where you have the ability to ask questions to world-renowned neurologists and researchers, and most people don't have the ability because of location or whatever to be able to see these people, and we're bringing it right to your living room. So that's so exciting. So tonight, please use this opportunity to ask your questions. That's why we do this. So along the same lines, we're also making it easy for researchers and neurologists and people who come on our platform to address our community, where there's hundreds of people on one call. So it's a win-win for everyone. So we understand that this journey can be difficult, so our platform is making it easy to share all this information. So it's exciting to be part of that. So we thank you for joining us. And now I'd like to welcome our presenter, Dr. Stanley H. Appel, who is an internationally known researcher and neurologist, 40 years devoting his life's work to diagnosing and treating patients with neurodegenerative diseases like ALS, specifically ALS. So thank you, Dr. Appel, for sharing with our community your expertise and your innovative research in regards to suppressing neuroinflammation with cell-based therapy for people with ALS. So we're looking forward to hearing what you have to say.
Well, it is truly an honor. And the reason it's an honor is I've labeled this disease for our patients and for all of you. ALS is what I call nice guys disease. And these are the nicest people in the world. They're the people most deserving in care. And our whole team is devoted to solving and helping, not only with quality of life, but hopefully with length of life as well. I've had a particular bias in terms of this disease, and you'll hear about my bias. But before I do, I want to tell you, importantly, why we think neuroinflammation might be a way to go. Okay, so here are two examples of patients with ALS. Dramatically different. When I talk about ALS, I don't talk about amyotrophic lateral sclerosis. I talk about scleroses. And the reason is that everyone is so different. People are different with this condition. And they go at a different rate, at a different age. Actually, Lou Gehrig, as you know, contracted this in his late 30s. In fact, Stephen Hawking contracted this. Its first symptom was in his early 20s. He went only several years, and Stephen Hawking went more than 55 years. And so one of the major questions that we have addressed is the issue of this heterogeneity. Why are people so different? Why are they different with respect to this? And I think there are potentially many different answers, but the approach we've taken is that neuroinflammation and the immune system may be a very important factor dictating rates of progression, onset, and survival. And that's been the devotion of my laboratory from a basic science point of view, and we'll talk about the clinical studies that deal with these issues as well. So I love this old issue of Time. It's almost 20 years old. And you'll notice that inflammation was important for heart attack, cancer, Alzheimer's, and of course I had to put ALS. So I just put ALS right in here because to me, this is the important issue. It is the secret killer, and how are we going to fight it? Now here's an example of what inflammation can do in a fire. And the amazing thing is you might only see traces of the fire at the edges, but look at all the damage that it's done. And so from my perspective, this is where we aim. Now, I'm going to go through and do the best I can to explain some of the basic aspects of how we got there and then the discussion. So in doing so, I just want to give you the evidence. For years, people said inflammation is not present in the spinal cord of patients with ALS. But many, many years ago, we discovered that there are cells, inflammatory cells, in the so-called ventral horn, and the ventral horn is the gray matter of the spinal cord where the motor neurons sit. And these were inflammatory cells. We know they're inflammatory because we stained for them as two different species of T cells, lymphocytes, and the other cell called the microglia or the macrophage. And these are two different types of immune cells, and we're going to talk more about that. Now here's another picture of what these microglia, these immune cells in the CNS look like, and they're activated and increased in the spinal cord of patients with ALS. Now, every one of my colleagues says you need to think about the genetics because that's the answer to why some people go fast and some people go slow. And this is just over the years, starting in '92, when all of this exciting data became apparent, are the number of genes where there's an alteration in that we call a mutation that gives rise to dysfunction, either because you've lost function or sometimes because you've gained too much toxic function. The first gene that was well recognized is superoxide dismutase, and it's responsible for 20 to 25% maybe of the familial cases. So that's 2% overall. The biggest gene is the one that you've heard so much about, C9orf72, and that's on chromosome 9. And this particular gene is responsible for, in some studies, almost half the familial cases. 50% of the, let's say, 10% or 5% overall. And a number of studies in patients have documented that even if you don't have a family history, some of the patients without a family history may even have this particular mutation. That's being studied in research studies now. Okay, so this says, let's look at the genes. And that is an important issue, but here's the way I view it. And it's like a funnel. And think of this, and I'll come back to this, as the motor neuron, in which the energy factories, the mitochondria are altered, and a whole series of different reactions, many of them dictated by different genetic mutations. But here's the issue that all of us face as patients, as clinicians. A different mutant gene can give rise to the identical clinical picture. So if you have a patient, let's say, that starts with speech and swallowing, the so-called bulbar onset, you can have that bulbar onset specifically the same with many different genes. So that makes it a little more complicated. Now, the converse is also true. Just because you have one mutant gene does not mean that you're going to have the identical clinical picture. In point of fact, there are different clinical phenotypes that can be expressed. Now, so the question is there a common denominator with all these different mutations? And the answer is yes. It is neuroinflammation. And what do we mean by neuroinflammation? We mean the macrophages or microglia, which is one innate immune cell, the T cell, and in fact, we also need to include the astrocyte that you've heard of. So all of these cells can participate in neuroinflammation. Now, what is the role of microglia in vivo, and how do we document this? So here are two particular extremes that we have. We have good guys that we call M2 macrophages and microglia, and we have bad guys that we call M1 macrophages and microglia. The good guys are enhancing protection, and the bad guys are enhancing toxicity. And this is just some of the neurotrophic factors, the growth factors that are released, and some of the molecules that we call cytokine. All of these are protective. However, when they become bad guys, then you have less of the protective elements and much more of the toxic elements, a variety of cytokines and inflammatory promoters like TNF-alpha, hydrogen peroxide. And all of these produce toxicity. Now, you can look at mutant SOD mice, which have been models, and when we look in the spinal cord, we look, this is the clinical picture of what happens in the mouse. It's slow and then seems to stabilize, and then it's rapidly progressive. And since the mice are all cloned, this is a pretty steady and predictable path, which is very different from patients and how we deal with it. But when we looked at this a good number of years ago, we found that during the early phase, the good guys predominated, the M2s. But during the toxic phase, the M1s predominated. So what we noticed is that early on, the good guys outnumbered the bad guys in this animal model. But as time went on, it began to shift. And then when the mice were progressing most rapidly, the good guys were no longer the bosses. The bad guys were outweighing the good guys. And that's the kind of model that set us on the path of neuroinflammation, the immune cells, good guys and bad guys. So if you look at this in terms of the immune cells, once again, the good Tregs are here, the M2s are here, and the pro-inflammatory in the latter phases are in fact the bad guys. So the goal here is how do we enhance it? So now we can go back, and a lot of my colleagues, when we first came out with this, said, well, what is the evidence that it's really important rather than something that happens later and after the fact? And the answer is in the mutant genes themselves. If you have a mutation, and we'll talk about a couple briefly, that is linked to ALS, that causes ALS, and that mutation alters the genes in a macrophage or a microglia, that can directly cause ALS. So, the innate immune system genes are the evidence, and I've just listed a number here, probably more, and I've listed the kinds of reactions that occur that give rise to inflammation that are linked to ALS. So what we're saying is that the M2s are in fact very protective. The M1s are in fact toxic and causing inflammation. And it is the ratio of good to bad, the good guys to the bad guys. So I know this is a crowded slide, but just look at this as a picture of a macrophage, a cell that can cause direct damage. This is the major cause here of familial ALS, as I said, the C9orf mutations. This is one of the most recent ones, and it's in the same pathway. So if this is fouled up, that leads to a foul up here, and you get altered gene expression. This is the pro-inflammatory pathway, so you make altered genes, and this is the disposal of the cell called autophagy. It eats up all the misfolded proteins and all the things, and if this is altered, this whole process is altered, and that gives rise to inflammation. So what we're finding is that in ALS, patients, as well as in the animal model, you have a movement from protective anti-inflammatory to pro-inflammatory, and the monocytes are skewed towards pro-inflammatory. So this is just to show you a picture. In ALS, the M1s are dramatically increased compared to controls, and the M2s, you see, are dramatically decreased. And if you take a ratio of the bad guys to the good guys, you find that the bad guys dramatically outnumber the good guys and compared to controls. So this was the first bit of evidence in our hands that in ALS, inflammation could be contributing. And this is just, we did study of all the genes and we confirmed what we had found. So let me give you a general hypothesis of the way we think about this, and our therapeutic strategy is earmarked. We've got a motor neuron here. The motor neuron, as I said early on, is supported by the good guys, and in turn sends signals back and forth. So the neuron says, please protect me, I am receiving a slight injury, and these are the protective elements that come back. Now, unfortunately, there is increased injury to the motor neuron, which we think precipitates the immune alteration and gives rise to neuroinflammation. There are a number of mutations that have been described that can do this, but in turn, as we said, the macrophage or microglia that are toxic send toxic signals to the motor neuron and injure them. And in addition, the T cells aggravate the situation. So the point I'm making here, and this is a very important point, the injury is occurring within the motor neuron. That injury is initiating the whole process, and lots of studies are going on with therapies to try and cut down the injury here. For example, for the mutations, let's say in superoxide dismutase, the SOD, elegant studies have been shown that you can shut off the injury producing SOD in motor neurons. And those studies are now reaching the point where they're in phase 2 studies with what we call anti-nucleotide oligo AGOS, because these are in fact ways to shut down the genes, or you can put the genes, you can shut off the genes directly with all sorts of new therapies. So antisense oligonucleotides can shut these down, as can viral invasions here. But we still have the problem of this process, which is enhancing injury. And so our therapeutic strategies are targeted at this process rather than using antisense oligonucleotides or viruses to shut off the injury in neurons. Although this is extremely important, and I think getting closer and closer to large-scale trials. Now, so what I've said is that the macrophages are activated by motor neurons, that early on there's a protection and later there's an increased injury process that has been documented in animal models. And perhaps by the time we see the patient, so much injury has occurred that we're in a pro-inflammatory stage and we don't see enough of the protective early stage. Now, in the presence of the pro-inflammatory macrophages, without motor neuron signaling, we don't get motor neuron disease. And what I mean by that is lupus. Lupus is a dramatic, unfortunate, dramatic inflammatory disorder, but does not give rise to ALS. Rheumatoid arthritis is a dramatic neuroinflammatory disorder, but targets joints, not the motor neuron. So you need some expression in the motor neuron. I just want to introduce a couple of T cells. I've talked about macrophages and microglia. I also want you to know that there are T lymphocytes. So the bad guys are Th1 and Th17. A good guy is Th2, but the best good guy is Treg, because the Tregs suppress the inflammatory response of the other toxic T cells. Now, I just want to introduce you to the experiment that put us on the path that I'm going to spend most of my time talking about, namely regulatory T cells. And here it is. We crossed a mouse, the mutant SOD mouse, with another mouse that in fact had no immune system, the RAG2 knockout, or was missing specific T cells. And we expected, if you do this experiment and you do this under circumstances where what you're looking at is, are you going to reproduce MS or Parkinson? It turns out that when you take out the T cells, most of them are toxic and the animals live longer. That isn't what happened in our experiment. The animal died earlier, which meant that we were removing protective T cells. And as you can guess, we put T-reg lymphocytes back in and the mouse lived 88% longer. That was the start of our emphasis on Tregs. Tregs are protective in the mouse ALS model. Where do we stand in man? So what's the evidence for neuroinflammation? Innate immune macrophages are increased. The T cells are altered. There's no benefit targeting a single one of the release of this. They've been tried in man, IL-6 antibodies, IL-1 beta, TNF alpha antibodies, things that work in other conditions like rheumatoid arthritis do not work in ALS. In addition, the individual growth factors have been tried, and unfortunately, they don't work. So here's the situation. You can't target a single toxic factor. What you must do is target multiple factors, including ones that you may not even know exist. And that's where cell therapy is important, because cells can target multiple factors at the same time. They can target the bad macrophages or the bad lymphocytes. So here's what we're looking at. Under normal circumstances, the T cell suppresses Th1s, that is the bad cells, and also the activated macrophages. But under circumstances where the macrophages are really dramatically pro-inflammatory, they can cause the Treg cells to go down, and then you lose the protective function against the bad guys and against the macrophages. Okay, just to show you the evidence, here is a measure of the gene expression specific for regulatory T cells, and it's less expressed in patients going very rapidly with ALS. And in fact, we can show it that if you have a high number of Tregs to begin with, you're going to do much, much better in terms of survival and in our scoring system than if you have a low number. As a matter of fact, a number of years ago when we published this, we already knew that a low number is associated with unfortunate faster progression and earlier demise than a high number. And we even have spread this out even more. You can, with the Treg suppression, the greater your ability to suppress, the less ALS burden. If you have an increased burden by our scoring, you have less suppression, and it's also true in progression. The slower the disease is evolving, the more suppressive function. So this is telling us that if we could suppress, that would be important. Okay, so what we know so far is the bad toxic M1s activated by injury are in fact inactivating the Tregs, and that in turn results in a feedback where all of this is self-propagating, and these T cells cannot suppress the Th1s at all. Now, what we found is we went into the laboratory and we said, can we expand these cells? And sure enough, we could expand them. And to our great surprise, when we expanded these cells, they turned normal. They became normally suppressive, and they could suppress bad T cells and bad macrophages. So what we said is, this is incredible. Maybe if we knew how to do this, we could go to patients, we could take out their T cells, which we know are dysfunctional, we could expand them and give them back their own T cells. And that's called autologous T-reg infusion. So how are we going to do this? Why are we going to do it? Well, just to give you a cartoon that gave me some ideas which I hadn't appreciated, is under circumstances in the ALS patient, the bad guys outweigh the good guys. The bad guys outweigh the good guys, and you're in an inflammatory situation. Why doesn't immunosuppression work? It turns out that most immunosuppressants suppress both the bad guys and the good guys. So what's happening here is you're not changing the ratio when you immunosuppress, which is why immunosuppressants don't work. I wish they did. That would be a way to go. So what we have to do is change the ratio and get the good guys to outnumber the bad guys. And the way to do it is to administer the Tregs to make the whole situation an anti-inflammatory situation. Okay, so we've said that it is functional. We've also said when we expanded them, the suppressive function is enhanced. And the question is, can autologous infusion of expanded Tregs provide therapeutic benefit? And now these three were our patients in our first study, and they gave me permission to use their pictures, and they were going at very different rates. And I wanted three different patients, one going very slow, one going at an intermediate rate, and one going very fast, to see to what extent this could work. And the only way we could do this is we were very fortunate that the Rizzuto Foundation and a new organization that we helped fund, ALS Finding a Cure, was formed to help patients, and they supported the first study together with the ALS Association. And so what we did is we grew the Treg cells in the laboratory, but it had to be a GMP facility. And this GMP facility we used initially was one that was provided. We contracted with MD Anderson that had a beautiful facility, and we arranged for the patients to get therapy every 2 weeks for 4 treatments to see what would happen. We got FDA permission for this. And when we did this, the amazing thing happened was this patient had been going for 8 months, and by the ALS FRS, which is one of the ways we monitor progression, the patient had changed 4 points. This patient here was going very slowly, and over 7 months had changed 1 point. And this patient here, over 7 months, had changed 4 points. When we gave this, amazingly, we stopped progression in these, and actually we may have even improved the situation here. So we got very, very excited about this, and we had the opportunity to go back into these patients or to take 3 new patients. The FDA said we could take a total of 6, but I decided that we would go back into these patients and see if we could help. And the reason I made that decision was because this effect did not last. And what happened instead was the progression accelerated, if anything. The slow patient still went relatively slowly, but these 2 patients went extremely fast. So over 9 months, this patient had changed 16 points, and over 4.5 months, this patient had changed 10 points. But the amazing thing to me was we then went to monthly infusions, and this patient changed 0 points in 4 months. Well, the patient was going slowly. Maybe that patient would have done that anyway. This patient dropped 1 point in 4 months, and this patient, so we got very excited because we were able to stop progression, but the patient had fallen off, and this was not a situation where you can give just 1 trial or 1 shot and expect any significant benefit. You needed to keep it up. And just to show you, the T-reg suppressive function improved, and then we went back in and it improved again. This is patient number 2, and this is patient number 3, and there was good correlation, and we published this paper with Jason Tonhoff, was one of the clinicians who's a physician scientist who was leading this effort. The breathing also seemed to stabilize, but in between it fell down. Now, so was it really a game changer? Is it really the way to go? Well, we found out that it was very safe and well tolerated. Expensive, extremely expensive, but still safe and well tolerated. The biweekly infusion slowed progression, but the effect didn't last. And the infused Tregs converted to other cells and were dying. The monthly Tregs late in the disease, or later in the disease, did promote clinical benefit, and it was also predicted by our suppressive function. So this really helped us in a way of saying, this is a reasonable way to go. It's not the only way to go therapeutically, but it's something that made perfect sense, and we had a way of monitoring how the patients were doing. But this study was limited. There were only 3 patients. How can we jump and say that only 3 patients is the way to go? Second of all, it wasn't placebo-controlled. We all wanted the patients to get better. They wanted to get better. But I will tell you, we used 2 different scales, and in both, there was improvement. Both of these scales were administered blindly, but the point is, the rest of us did know when we were infusing what we were infusing, and so we were concerned that it wasn't placebo-controlled. But it was safe, at least in 3 patients, and we needed to learn how to sustain the Treg suppression and clinical benefit. I had been contacted by a number of patients after that first study, and rightfully so for me, I would have contacted me because they wanted to get enrolled. And I said, number one, resources are needed. We need to raise the money for a second study. But more importantly, I don't understand why it doesn't last. We absolutely need to do things to help make it last, because I don't want to go into a situation where we help people for a couple of months and then they fall off the mountain after that. That's not fair to anybody. We need to know more. So to try and deal with that issue, we are in the midst now of a phase 2A study. We needed to learn not just how to expand the Tregs, we knew how to do that, but how to freeze and thaw these for repeated infusions. Because what we wanted to do was to give monthly infusions for a year, not just for a couple of months, to overcome the pro-inflammatory environment. We also wanted to do it in at least for 6 months in a placebo-controlled trial. So for 6 months, the patients would not know what they were getting. And then for the second 6 months, we would open it up, the open label extension, and we would actually look at we would give a dose, then we would double the dose, and then we would triple the dose over 6 months for safety and to see if it would help and prolong meaningful quality of life. We were able to successfully get support from the ALS Association, from the Muscular Dystrophy Association, as well as from ALS Finding a Cure. And we wanted to do this in 2 different sites, not just in our site here, but we wanted to do this as well under Merit Sokovich and James Berry in Boston and Mass General. And so what we were going to do, the plan was that we would set up a study in which 6 patients would be on Tregs, 6 patients on the placebo, and this would be a double-blind, and we would not know, none of us would know that. Now, we made arrangements for 6 patients to fly from Boston to have the cells taken out, and 6 patients would be taken from our clinic here in Houston. And then you all knew what was going to happen, and it did. COVID-19 hit. And COVID-19, unfortunately, prevented 6 patients from coming from Boston. Only 3 were able to do it, and then everything was shut down, and not only the plane flights, but what was going on in Mass General as well as Houston Methodist. So we had 3 patients here and 3 patients from Boston that were already enrolled in the study. We had learned how to freeze the cells and thaw them so that they were viable, and in addition to being viable, they were suppressive. This took Dr. Tarnoff a fair amount of time to work that out, but we were able to do that. And we were fortunate enough now to collaborate with the University of Texas at Houston under Fabio Triolo, and we have the GMP facility, which allows us to expand the cells, make sure quality control, not only are they pure, but as well they're safe, not infected, and we passed all government studies with respect to this. This just shows you what we did on the viability. So these cells, these Tregs, before expansion were about 70% viable, but after freezing and thawing the expansion, they're almost 100%, these 3 different subjects. And this is 1 month after freezing and thawing. We're now out to a year, so we have patient specimens that have been frozen for a year and are still viable. And then when we look at the suppressive function, they're very low to begin with. As I told you, this is what we know in our ALS patients. And following expansion, they really are very potent cells, and these are the cells that were infused. Okay, so where we are now is, this is when we got started in September 2019. We're now up to this point in now we're beyond this, but the point is 3 of the patients from Houston and now 2 of the patients from Boston have reached the 6-month and are ending the double-blind component of the study and are in fact now in the open label. And in addition, we had enrolled 2 patients just in the open label, and they're in fact almost finished with their 6th month at the open label. So a total of 8 patients, and 2 patients we were unable to expand their Tregs. So there were 6, 3 from Boston, 3 from Houston, and 2 in the open label extension. And this is the first infusion that was done in our patient. This is our good guy here, and this is his lovely wife. This is Jason Tarnoff, who led this study, and 2 of our nurses. This is led by Patty Mendoza, and Rachel Applegate is our other research nurse, who are helping there. Actually, Rachel is not a nurse, but she is a fabulous research coordinator. Okay, what have we learned from this study and where to next? Not all patients respond similarly to the autologous infusions. Now, we know, or we thought from the first study, that everyone would respond. We also know, without knowing what happened in the double-blind study, in the expanded study, 1 patient from Boston and 1 patient from Houston have not responded to the Tregs, to their own Tregs, even though we put in large amounts. We assumed that everyone would respond based on the first study, and that is naive. Now, we are excited because in the open label, we're getting a hint of some of the kind of benefit that we did get, but keep in mind that if not everyone is responding, this is precision medicine. Not everyone is going to do it. We're hoping that a majority might do it, might benefit, but we don't know the answer to that until this study is over, and it will not be over until the spring, early spring of 2021, when the last patient finishes all of the 1 year of being in the study. And we need that information to know what percentage of patients respond, how many will respond, how are they going to do. We're in the process of determining how the Tregs are working. This is important. And most importantly, if the Tregs are not lasting and the patients are getting into difficulty, even if it's after they've done so well for a while, we need to know how to extend the viability of the Tregs as well as their suppressive function and preventing their undergoing apoptosis. We also need to learn how to scale this, and we also would love to be able to consider not just autologous approaches, but using other populations to help provide the Tregs, and this is a holy grail way off in the future. Well, I just want to tell you that these are the players who really were helpful in initiating Mr. Rizzuto, who unfortunately is no longer with us. but what a fabulous human being who was committed to helping solve ALS. Peter Foss, who was a prime mover in assembling ALS, finding a cure. Merit Sokovich, who has been on one of these calls and is the sensational leader of neurology in Mass General and one of the greats in ALS in the world. Myself, Bob Brown, and Clive Svensson, both of whom are world leaders, and Clive was just on, and other members of the committee, part of GE and part of our committee. And I can't end without showing you our ALS clinical team. Our clinic has been running for longer than I think any other clinic in the world as a multidisciplinary clinic. We started in 1982, mid-year 83, and has been running continuously since then. And we have an absolutely fabulous group of committed people, all of whom are interested in solving this. We're all dedicated and devoted to our patients, and the reason we're here is because of them. So I'll close on that note. Thank you for your attention, and of course, be happy to answer any questions you might have.
And this was an excellent presentation. And I think we have a lot of questions that's come on chat, and I will introduce Zoe Lalji and also James, who are gonna actually ask you the questions. You might have known Zoe. Zoe's father has been diagnosed with ALS, and she just started at UT Austin as a freshman, and James is a junior at USC. So we're glad that
I know her very well. She's a fabulous young lady.
Yes.
Oh, thank you, Dr. Appel. It's good to dashing in his bow tie, as always.
Yeah.
Given all the types of ALS, is there a certain type that you think might respond better to your therapy?
That's a fabulous question. And I would have made the assumption that that would be the case, that some patients would respond better or worse. That has not been the case. What is interesting, and that's why I showed the early slides, what is interesting is there are many ways to produce the motor neuron injury, but once the injury is occurring, then the neuroinflammation takes off from there. So the neuroinflammation, if you've got a more severe injury, and some of the patients with the forms of familial ALS may have a more rapidly progressive injury, those patients have a dramatically increased inflammatory response. So what we found so far is that the key issue is the nature and the extent of the inflammatory response, and I think that's going to dictate what is going on. Now, having said that, Zoe, your question is a great one, because the issue is, why is there the patient, as I said, that we know, I don't know what happened in the double blind, but I already know that that patient has not responded in the open label as effectively as we had hoped. And we don't know the answer to that question. But for the moment, my answer to the question is, no, I do not think that there are going to be subpopulations that will not respond, but we need more studies to determine the answer to that question.
Okay, thank you.
Hi, Dr. Appel, James here. Jump right in as well, because we've got a lot of questions tonight. Very good. Are there any genes that control Treg function, and how do you collect the T-reg cells, and how did the infusion occur, through an IV or a port?
Okay, great, all of them, great question. Number one, yes, there are genes that affected it, but they don't seem to be genes that are compromised in ALS patients. Most of the genes that we've talked about compromise the macrophages and microglia rather than the specific T regulatory cells. But The important gene is called FOXP3, and we know that if FOXP3 is in any way dramatically altered, the patients have unfortunate systemic alterations and get into major trouble, and that's known with a mutation, of in the FOXP3 gene. So that's been known for a while. The second question, it's relatively easy for us to expand in vitro. As I said, it's quite expensive to do so because you have to be in a special facility called a good manufacturing production facility. All stem cells need to be done in that. And unfortunately, there are all sorts of charlatans throughout the world who don't conform to these FDA protocols, and the patients get into major difficulties with infection. With respect to the infusion, the beautiful thing is we're in a small number of cc's. We don't need a port to go in. You're putting in a very small amount, 5 to 10 cc's or thereabouts, and you can put all in. And now in the second study, the number of infusions is close to 70, and all have been safe, which is amazing because it's telling us that the quality control, which is a key factor, is doing well.
Okay, thank you. So the next question that we received is your trial available for expanded access? Where is the therapy available, and how many people will be included in the next phase of the trial?
Oh, I wondered when that question was coming. That's a triple header, a beautiful triple header. Okay, number one, we are not enrolling any more patients. COVID-19 shut us down at 8, unfortunately. So we're concerned about that. Number two, we have not answered the question of total safety. That's really a key issue that we haven't been able to determine what are the consequences when the patient doesn't respond. As I told you, we've had 2 patients, one from Boston, one from Houston, that have not responded. We don't think that it's a major problem, but until we have better insight into that, and whether that's common or uncommon, we can't consider going to a much larger study. So we're trying to learn as much as we can now, because when we go to a larger study, we want to make sure we've learned enough and we've learned how to deal with the issues. And the third question has to do with how scalable it's going to be. How many patients can you put in? Right, and that's another thing that we're learning how to do. Right now, in the first study, we put in 1 patient a year for 3 years. In the second study, we've put in now 8 patients in a much shorter period of time, namely in about 8 months or so. We need to get it to a point where we can put in at least 2 patients a month or even more, and that's what we're aiming for. We are not there yet, and so the issue of scalability is of great concern, even before we discuss how expensive it is to do these. But given the antisense oligonucleotide studies, as well as the virus studies in SMA, where so much is involved, it's interesting that insurance is covering or will be covering those when you make a major impact on motor neuron disease. So I hope I've answered the question that was raised.
Yes, thank you.
Next one for you is, what is your opinion about NAD plus supplement bias by Elysium? And for symptomatic and pre-symptomatic gene carriers, do you consider NAD if it has any impact on ALS patients? And if so, is this part of your protocol?
Okay. Number one, let me go in reverse. It is not part of our protocol. We do put patients on a variety of vitamins. I think on the preclinical work, there's certainly suggestion that NAD may be very meaningful. But unfortunately, to my knowledge, there's not been a careful double-blind scientific study indicating safety, tolerability, and efficacy. And so, you know, I know we're all concerned about the issue of to what extent should we be doing double-blind studies when patients are suffering? The problem is, I will tell you, one of my interesting experiences was with one particular wonderful man whose wife was affected, and he said, "Dr. Appel, what is bothersome to me that in fact, when you're doing this, most of the studies that you're telling me about, it turned out the placebo did better than the patient on the experimental medication. And that's true for a good many years. In other words, it was harmful." So this guy turns to me and said, "Dr. Appel, where do I buy the placebo?" Anyway, that was, I said, we have plenty of those available. They're littered throughout ALS history, therapeutic history.
Thank you.
Now, let me come back to, I apologize, I didn't answer one of the questions, I think with regard to extended access. Right now, I'm a little concerned about extended access when I can't predict all the parameters of someone who's going to do well. We hope that we can get to that point. Obviously, there's a cost issue and everything else, but from an understanding of how to help people, we're not there yet.
Okay, perfect. Thank you so much. Our next question is whether the impact of Treg cells has an impact on autophagy.
That's a great question. And the answer is yes, it does in the following way. The Treg cells work on macrophages to suppress the inflammatory response. When the inflammatory response in the macrophages are in fact somewhat improved or considerably improved, then autophagy is in a better position to digest some of the proteins. In other words, if you help repair the injury process, then by helping to repair the injury process, autophagy is improved, not just in the motor neuron, but as well in the macrophage itself.
Okay, thank you.
All right, the next question is actually one I've wondered about as well, so I'm glad it was asked. In your opinion, do you think that doctors in the US typically discourage their patients from going elsewhere for promising treatment? What is your opinion on that?
That's a great question, and boy, is it loaded. But that's okay. I see the smile in your face, and that's why you're asking it. Okay, so the issue is, you can dissect that question in a number of ways. One, are you going elsewhere because the cost of the medication is infinitely cheaper than it is in the United States? That is a concern, where drugs in the United States can cost considerably more than drugs elsewhere. I'm thrilled, to be honest, that by now what we're doing is we're concerned about riluzole as one therapy. We're concerned about edaravone, which is another therapy. And at least riluzole, now that it's available generically, is in fact relatively cheap with most insurances. I had a patient that I saw this morning. When we checked to see what riluzole would cost her, it cost $0 because of insurance through the post office that her husband had. The VA, many of our patients who are veterans get riluzole $0 from the VA. And some insurances unfortunately don't, but we feel very strongly that that's an important drug that should be used. And quite honestly, I don't think there's any reason to go to any other country with respect to this issue. The third part of this equation is one that's always important. Can you trust quality control? Can you trust quality control in various places? I can't tell you the number of times we've been hopefully beneficial to our patients by shutting down some of these fraudulent stem cell factories that charge a fortune and don't have quality control, and in fact are getting our patients into trouble. We worry about that. So from most points of view, I think we do a good job. Now, the issue is going to become, are there drugs available in other countries, which is the final point in your question, that we should be trying that we're not allowed to try in the United States? To my knowledge, there are none such. One of the good things about the ALS community internationally is the fact that all of us are in constant correspondence with one another, trying to do our best to educate one another to get all the drugs to patients as quickly as possible. So I am not worried about other countries having drugs that our wonderful patients here can't use. I hope I've covered many of the aspects of your question, James.
I think you did, but we do have a little bit of a follow-up. Specifically, what about CoreStem in Korea? The approved stem cell treatment for ALS in Korea.
I happen to know that very, very well. And the reason I know that very well is Sung Kim, who leads that, trained with us here in Houston, Professor Kim. Now, so they are different than Brainstorm. And I happen to be a scientific board advisor for Brainstorm. What they do is they take, we're talking about CoreStem in Seoul, Korea. They take the cells out, and instead of modifying them as Brainstorm does to increase trophic factors, they will give them right back to the patient. But I think their data is pretty good, and it's saying the same thing that I think all of us know, and that is with any cell therapy, a one-shot deal is not going to be enough. You have to go multiple times over a period of time. So let's say you go 2 times to Korea, and it's $50,000 to $60,000. That's a lot of money. But how many more times do you have to go that year? How many years do you have to continue to go? How long is this going to last? We don't have the answer to that question. In this country, Brainstorm, as you know, is in the middle of a phase 3 trial, which hopefully we'll get the answers to in the next number of months, maybe early next year, and we'll know how many times they had to be treated and how beneficial it was on the patients in a really effective double-blind study. We don't know the answer to that question, but one thing for sure, and I am, one thing about Dr. Kim, he is fabulous. He's a person of the highest integrity, and they're trying to do their best for the patients. But it is very expensive. How many times you have to go, and as much as, and then the other thing that I think our listeners know is that when you in fact have to give it, you have to give it into the spinal fluid. And if we're going to have to do that every 2 months or what have you for on and on, that's a lot of therapy going into the spinal fluid, and there may be other side effects of that problem.
Thank you.
So the next question is asking if your treatment modality is scalable to a larger patient population, and if there are ways to drive down the cost of Treg expansion and infusion.
Both those questions are fabulous. And let me just say, I think I addressed that, the scalability. Right now, we're working very hard to improve our manufacturing so we can do this on a more scalable basis. By scalability, I'm not saying 100 to 200, but I'd like to be able to get to 30 to 50 to 60, and we're not there yet because of the manufacturing way we have to do it. So that's the critical thing. The other thing, which is also exactly very important, is the cost. The cost of a GMP facility is critically important, whether you're doing bone marrow for cancer or you're doing T-regs for ALS. And we're doing our best to lower the cost. The more we can improve manufacturing, the more scalable you can make it, obviously the cheaper it's going to get, because it's the length of time and the number of expansions you have to do in a GMP facility that costs the money. So yes, that's a goal we're working on right now.
Excellent. Good to hear about that. Do you also look for those common genes and or cells when you do the 2-day workup on patients?
Okay, you really have up-to-date information. For 20 years, we did 3-day workups, and it's only in the last 2 months we're doing 2-day workups. So you have, and that's because I'm transitioning away from the chair of neurology towards running cell therapy here, hopefully to benefit our patients as well as transplant patients in it. And the answer is we send off laboratory tests on every patient with any hint of a genetic mutation, i.e. a family history in the family. But the second thing is we're part of several studies that in fact allow us to enroll patients in genetic programs, genetic study programs, one run by Matt Harms in New York at Columbia, which allow our patients to get their genetic information ongoing and without any cost.
That's great.
Thank you. The next question is wondering whether the participants that were in your study made any dietary changes. For example, if removing inflammatory foods could possibly help with the inflammatory processes.
I think that's an interesting question, and I don't know the answer to the question, but I'll give you a biased approach. There is no evidence that I'm aware of any food that makes ALS worse unless it's causing a dramatic increase in saliva, causing coughing and choking, and causing difficulty in swallowing. Any food that can do that is a food that needs to be avoided. But those foods like potato chips or popcorn or things like that are not necessarily causing an increase in inflammation. They're in fact causing direct problems in the swallowing mechanism. So I'm less concerned about drugs or nostrums or supplement to give inflammation, because by and large, most of them don't. Just as most of them don't solve the problem of ALS, nor do most of them help us have better memories or anything like that, like you can see every day on TV.
Okay, thank you.
Next question. Do you look at the mitochondria density in the macrophages that you study?
The answer to that is no. We don't do that, because if you're going to do that, we actually did that. That's a very astute question that was asked by someone. We actually did a study on that with one of my colleagues from Hungary, and this colleague who is a fabulous researcher. His name is Professor Laszlo Siklos. We looked at the nerve endings in ALS motor neurons by biopsy, muscle biopsy. And when we looked there, in ALS, we found dramatic alterations in the mitochondria of the presynaptic terminal, that is the terminal of the motor nerve as it's coming to connect with the muscle. And we saw dramatic increases in calcium. So we have not looked at in the mitochondria. That is not really a major problem. The macrophage problem does include one of oxidative stress with the mitochondria, but that's more a problem for the motor neuron than the mitochondria. The mitochondria is spitting out all sorts of bad guys that are injuring everyone surrounding there, and is not subject to the same problems of oxidative stress that we're seeing in the neuron. Eventually, obviously, the macrophages themselves may undergo death from oxidative stress, what have you, but it's not in the early phases.
Thank you.
Okay, so the next question we received is wondering whether of the ongoing clinical trials, which ones do you believe show the most promise for the care and cure of ALS?
Oh, wow. Boy, is that a politically loaded question. Interesting. Okay, so I am a big fan of the study, the Healy platform study. Obviously, we're part of that study, and I think that it's an important one because it reduces the number of placebo patients in the given trial, and at the same time is testing a variety of drugs. I think the Solaris trial is a good one. Do I have a favorite one? No. I think any trial that is helping patients and that is safe is in fact an important trial, and whether it be the Amylex that was just published about, I think the data are there. I think everyone should be looking at, but I think we need the kind of scientific evidence that says something is safe, is not harmful, is well tolerated, and hopefully will work.
So the next question is in regards specifically to the C9 mutation. And the question is, what do you think about the antisense drugs?
Well, I think that's a great question. And the simplest answer is I'll have better thoughts when I see what the preliminary results are showing, which we don't have now. There are studies ongoing. I think, as I've expressed to all of us this evening, I think that the injury in the motor neuron is triggering a lot of the inflammatory processes. As a result of triggering that, then if you could shut down the injury process in the motor neuron, you would be accomplishing something. Now, I've also shown you that C9orf alters the macrophage and microglia themselves. And beautiful studies have shown that elegantly. Nevertheless, if you could shut down the injury produced by the C9 or 72, and an elegant study published just last month, or this month, earlier in the month, by Bob Balow, Professor Bob Balow at Cedars-Sinai, said, we're beginning to understand exactly how C9orf may be working, and it's working in inflammatory cells. So what is clear is if we could shut that down, that would be wonderful. So it remains to be determined, is the study safe? Is it effectively shutting it down? Does it have other side effects, etc.? The kind of standard issues that have plagued the ALS field for years, when in fact the placebo patients do better than the patients on the trials. We've got to avoid that.
Thank you.
Okay, you mentioned before that the number of Tregs impacts the progression of your disease. And someone was wondering, based on that, how they might be able to find out how many Tregs they have.
Oh, that's a wonderful question, except that isn't what I'm trying to convey. It is not the number of Tregs that count. It is their function that is most critical. So that's the first and most important thing. The second, so are they able to protect normally? The other major point that I want to make, and so I want to reinforce it, it is in fact the degree of their dysfunction, where they're not working well, that's more important. And then the final point is it's the ratio of good guys to bad guys. If there are more bad guys living in you than good guys, you're not going to get the protection from the good guys you want. So all of these issues are playing on this, not just the number of cells any of us may have. It turns out that it's of the order of 4 to 8% of our CD4 population, but that isn't a good answer giving you specific number. We know the numbers in all our patients as we go through this, but it's not the number, it's their function and their ratio between good guys and bad guys that count.
Thank you.
Simple mathematics. Have you found any correlation with Lyme disease or toxins and ALS as one that creates or even accelerates ALS?
That I thought was a 20-year-old question, but in fact it keeps coming back to haunt us because of the number of Lyme disease doctors out there. And there used to be a laboratory in California that could send back data that said that everyone has Lyme disease. Oh, no, I mean just everyone with ALS has Lyme disease, or everyone with schizophrenia has Lyme disease, or what have you. I can tell you that we found one case in several hundred. We do Lyme titers on everyone, but we make sure it's going to a legitimate laboratory, CDC approved, etc. But we found one case, we did the treatment, and it didn't benefit. That doesn't mean others may not benefit. Wouldn't it be wonderful if, in fact, ALS was curable by therapeutics for Lyme disease, because these are antibiotics that we use every day, and we'd love to be able to do that. And I wish we had a positive answer to that question.
Thank you. The next question is regarding riluzole and your thoughts about the drug itself and whether it affects familial or sporadic cases differently, and also that many find that riluzole causes intense fatigue, and whether you feel that the positive effect of the drug outweighs the side effects.
Okay. So I'm a big fan of riluzole, especially since it became generic and the price has dropped dramatically. It used to be $1,600 a month. Now we have patients getting it for $0 or $5 a month. That's wonderful.
So this doctor thinks that Riluzole for
I'm sorry, I hadn't finished.
That's okay. Go ahead and finish the thought you had.
Okay. All right. So it used to be said that Riluzole only prolongs life at the end of life by 3 months, and therefore a lot of doctors wouldn't describe it. That is not the situation at all. That is a fallacious notion. Number one, Amar Al-Chalabi in London has shown elegantly that in fact it helps respiratory function in ALS patients in a significant way when their respiratory function is altered in what he calls stage 4. So from our perspective, that's very exciting news, and it works and is terrific. The second point, studies have been published that show it prolongs meaningful quality of life between 6 months and 19 months. That's a dramatic drug, and I didn't get the side effect that someone mentioned, but I will tell you the number of side effects we've had with Riluzole are minimal. It can occasionally increase liver function tests. We stop the drug for a month and then put the patient back on it, and some of them can resume it. So we have not had bad side effects. So I'm a big fan of signal to noise ratio in people as well as in drugs. So if someone isn't making a lot of noise, then their signal can be almost infinite. And that's true of drugs as well. So I think Riluzole doesn't make much noise and is cheap. And by gosh, I want our patients on it.
Love hearing that.
Thank you.
The next question is, what is your opinion on the Dr. Bedlack documented ALS reversals where most only used natural products?
I think Dr. Bedlack is fabulous. He's a great clinician. I happened to tune in to his YouTube presentation, and I thought it was terrific. I also have had an experience, or many experiences similar to him, when a patient asks me, Dr. Appel, do any patients ever get better? The answer is yes. And so here's the problem. We have patients who, in fact, for 7 years don't change. For 10 years, 15 years, don't change. And what we don't know in those patients until we follow them, is it in fact that they're absolutely stable, or is it in fact that the disease is similar to Hawking's and is going to go 55 years? Okay, that's someone not changing. Have I ever seen patients that I were absolutely sure had ALS that in fact got better? And the answer is yes. It's not often. It's relatively uncommon, but it does occur. So I applaud Dr. Bedlack, because getting those cases and understanding what is going on in those cases is critically important. However, I would remain a little bit skeptical if I'm insisting on scientific rigor with NAD and a number of other things. I'd insist on the same rigor that would say, do we really know whether any of these supplements are making a difference or not in a real double-blind test or not? And the answer is we don't.
Thank you.
Thank you, Dr. Appel. So this is actually the last question we're going to be asking you tonight. And there are plenty of other questions that we will email you for a response later. But we realize the value of your time, so this is going to be the last one. And before I say it, I actually just want to say a special thank you to Dr. Appel for treating my dad for ALS, and he's been amazing for our family. So thank you so much.
Well, before you ask your question, I want to add that you have an amazing family. You have an amazing dad. Your mom is incredible, devoted to doing everything she can to help her wonderful, wonderful husband, and you're a very fortunate young lady.
Thank you so much. Okay, here's the last question of the night. Given these different pathophysiologies of ALS, do you believe that ALS patients should try to gear towards a clinical trial that targets a particular pathology?
That's a fabulously sophisticated question. I love it. And the answer is, we're not sure which of the pathologies are going to be most relevant. So I'm sure, of course, it's neuroinflammation. So I'm very excited about the trials targeting neuroinflammation. But I don't want to rule out that there could be many other pathways that could be benefited. And I think every single one of our patients ought to be in some clinical trial helping them. I think that's critically important. It does many things. One, it allows us to decide what therapies may be helpful, but I think more critically, it gives every one of our patients and their families, as well as the treating team, hope. Hope is the mainstay right now for all of us, and we all have hope. And I think patients ought to be in trials independent of the pathway.
Thank you so much. And that's true for hope. That's very true.
Thank you, Dr. Appel. We really appreciate you spending the evening with us, and we thank you on behalf of, over, 200-300 people joined us today, and we're really excited to know more about your trials and how it would be a treatment for ALS.
Thank you very much. It's been my pleasure and my honor.
Thank you. And we have some more questions, like Zoe said, and if you don't mind, we'll send you an email with the questions and be connected with you.
All right, that's great.
Thank you.
Take care, and everyone stay safe and cure ALS. That's our mantra.